Good morning, Loris. How are you? Can you hear me okay?
Yeah, can you hear me?
I can. I'm on my headphones. I just want to make sure you can hear me okay.
No problem. It sounds good, yeah.
Okay, very good. I'm excited about this.
It's going to be great. I already pressed the record button, so everything we're saying is being recorded.
Det her er Tim Phalen. 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 Hvis du skulle have lyst til at google ham.
I very much appreciate the opportunity to be included in this today. For the last 26 years, I suppose, my full-time job has been to go anywhere and talk to primarily paramedics and nurses about 12-lead ECG, STEMI, STEMI alerts, cath lab activation, and whatnot. So in that time, gosh, I've presented over 100,000 folks, more than a dozen countries, a few thousand plus seminars, written 4 textbooks. So
Han er en international ekg-ekspert.
just challenge yourself to say, you know what, I can do this. The goal is to help people succeed. There's just no shortcut. You're able to make good decisions in a variety of situations. You can become the master. You can become the Yoda of 12 leads if you so desire.
Tims store passion er ekg-fortolkning, STEMI genkendelse og aktivering, eller korrekt aktivering af CardLab. Stedet, hvor de akutte PCI'er udføres. Inden jeg går videre med podcasten her, så vil jeg lige nævne, at hvis du bøvler lidt med det engelske sprog, så lyt til afsnittet her på YouTube, for der kommer en tekstet version op der. Okay, da jeg snakkede med Tim, gik det op for mig, at han ikke er vant til at undervise ambulancefolk, der har et system som vores til rådighed. Altså det vil sige, sende et ekg til en kardiolog og få et svar tilbage og have en samtale med vedkommende. I USA, selvom det nok ikke er over det hele, er der ikke mulighed for at sende et ekg til en kardiolog, og ej heller altid mulighed for at snakke med en om, hvad der nu skal ske for den patient, vi har i ambulancen.
You actually get a phone call from the cardiologist so that you can have a conversation. Love that.
Det er min påstand, at vores udgangspunkt og det system, vi arbejder i, er med til, at vi undgår nogle af de fejlagtige aktiveringer af CardLab, som Tim underviser kollegerne i at undgå. Og i sagens natur, så aktiverer vi jo kun kardiologen, og ikke selve CardLab.
And even if you're only 5 minutes from the hospital, your actions can save a disproportionately greater amount of time to reperfusion. We are truly in a privileged position. And of course, that reduces mortality. That reduces morbidity.
Jeg er helt klar over, at der er nogen af jer, der vil spørge, om ikke vi faktisk er ret gode til at genkende STEMI og sørge for den endelige behandling. Og jo, det tror jeg egentlig, vi er. Men jeg er også, da jeg talte med Tim Phalen, blevet klar over, at jeg i hvert fald selv har en del blinde vinkler, der i sidste ende kan gøre, at jeg ikke får aktiveret kardiologen og dermed ikke får givet patienten den rigtige behandling. Måske kan jeg ikke projektere mine mangler over på jer alle sammen, men jeg bilder mig ind, at jeg ikke er den eneste, der har utilstrækkeligheder, der nemt kan rettes ind. Så hvis vi er så godt med, når det handler om STEMI-patienter, hvorfor så snakke om STEMI-genkendelse? Da jeg selv spekulerede lidt på det, kom jeg til at tænke på, at der faktisk er en masse patienter med brystsmerter. For dem kører vi rigtig mange af, og jeg er i tvivl. Og når jeg tænker lidt mere over det, så er der mange forandringer på et ekg, der ligner ST-elevationer, men ikke nødvendigvis er forbundet med STEMI. Mit navn er Ulrik Jørgensen, og jeg er paramediciner på en helt almindelig ambulance i Region Sjælland. Velkommen til IMS Podcast. Jeg har et anstændigt niveau, når det handler om at fortolke ekg. Så langt så godt. Jeg er ikke ekspert, men det behøver jeg heller ikke at være.
There's stuff that I love to talk about that's interesting, but I realize it's not necessary. So there's nice to know and there's need to know. So what I start with is, what's our operational goal? I guess what I'm saying is, you don't have to know it all. In that, rather than be intimidated because you don't know it all, challenge yourself to learn what you need to know to do the job well.
Når jeg snakker med kollegaer og elever, så er det som om evnen til at fortolke ekg er tæt forbundet med, hvor god en ambulanceperson du egentlig er. Det hænger naturligvis ikke sådan sammen, selvom det er vigtigt, at vi kan fortolke et ekg.
I think 12 leads are unnecessarily kind of viewed as being mystical or difficult, and they're really not. You could use a 12 lead to plumb the depths. I mean, a really good 12-lead interpreter, the amount of information they can draw from that is just uncanny. And it just kind of intimidates people. And I think they go, gosh, I would never be able to do that. Well, that person who's doing this, he didn't learn this or she didn't learn this overnight. It wasn't like they spent 10 minutes and did it, you know? And so I think sometimes we think that to be proficient with 12 leads in our world, we need to attain some profound level of proficiency like these masters do. We're using a 12 lead for a very specific purpose. We may not know all the nuances of left atrial abnormalities, but if we understand this finite body of information that we need to master in order to do our job and to make better cath lab activation decisions, better STEMI decisions, that is completely attainable.
Tim er vant til at undervise ambulancefolk, der ikke har samme åbenbart relativt unikke mulighed for at sende et EKG til en kardiolog og endvidere få en samtale med selv samme kardiolog om, hvad planen er. Men på samme måde som vores amerikanske kollegaer skal aktivere CardLab, hvilket vi ikke skal på samme måde, så skal vi stadigvæk tage en beslutning om at aktivere kardiologen på baggrund af det EKG, vi sender, og på anamnesen.
Now, as I understand it, you guys are doing ECGs. If you think there's something wrong, you're going to send it to a cardiologist for review. I love that. And here's what you guys do that I wish the rest of the world would catch on to. You actually get a phone call from the cardiologist so that you can have a conversation. That is amazing. Most places in the world just send the ECG. So all the doc is looking at is just the waveforms. And what's missing is the clinical presentation, which is huge. It's a both and. Both the clinical presentation and the ECG go into the decision making.
Og det er vel i virkeligheden udgangspunktet til vores tilgang til EKG.
And we get to the ECG, and maybe we didn't do a great job of acquiring it, and maybe there's some artifact, and maybe that baseline is wandering, and they're sweating, and so the electrodes are loose.
Okay, så det hele starter med, at vi sætter elektroderne ordentligt på. Det virker ret basic, men spørg lige dig selv, om du egentlig bruger noget som helst tid på at klargøre huden, og sørge for, at der er optimal kontakt mellem hud og elektrode. Jeg ved i hvert fald, at det ikke er noget, jeg har tænkt synderligt meget over selv.
Take a few seconds before you apply the electrodes to prep the skin. If you don't have a clear ECG as your starting point, doesn't matter who you are, it's hard to interpret it. The number one issue producing artifact is the electrode-patient interface. It's the gel. The better that gel penetrates, the deeper that gel penetrates, the stronger the signal from the heart, the weaker the signal from the sources of artifact, the cleaner the ECG.
Så når det er optimeret, og vi skal genkende et STEMI, så husk på denne grundlæggende regel. Det er okay at være i tvivl. For det er læger og sygeplejersker også, når de kigger på EKG'er, selv kardiologer. Så hvad gør de så?
Even the cardiologist sometimes looks at the patient in the ECG and scratches their head. So here's the first point. If cardiologists have three categories, yes, no, maybe. If emergency physicians have three categories, yes, no, maybe. Do we think we're better than them? And we should be able to always say yes or no. That's just not reality. So when I speak to paramedics, here's the visual that I use. I've got a screen and I've got three circles. One's black, one's white, and one's gray. If we think we're supposed to call everything black or white, as soon as you run into gray, you don't know what to do. But if it's allowed to call gray, if it's encouraged to call gray, then that is a well-defined system.
Og det er der, vi starter med en brystsmertepatient og et EKG, der viser STEMI, ikke STEMI eller noget, hvor du er usikker. De tre kategorier. Sig det, at du er sikker eller usikker. Og kontakt så nogen, der kan hjælpe dig med at tage en beslutning. For den beslutning, du tager, er vigtig. Altså beslutningen om at kontakte kardiologen.
There, in almost every EMS system, there are a surprising number of patients who would benefit from going to the cath lab, and they are not identified in the field. I mean, we know that happens. And I'm not being negative. It's just being real. Is that in a lot of EMS systems, maybe 20, maybe more % of the patients who could be activated are being missed. So that's one operational goal. How do I increase correct recognition? I start off, I put 4 complexes on the screen. 4. That's it. And I ask the group, how many of those have ST segment elevation? And I say, go. And everybody raises their fingers, either 0, 1, 2, 3, or 4. And we look around, and there's no consensus. And I go, that's our problem. We think we know how to find ST elevation. we don't even agree. So we go over how to find elevation correctly, how to do that, so that we're all consistent.
Og der er jo årsager til, at vi tager fejl. Årsager til, at vi ikke aktiverer kardiologen, og derfor risikerer at overse et STEMI. Her er den største forbryder nok, at vi tror, at der kun er én slags ST-elevationer, der gælder.
Flip side of the coin. There was no ST elevation. Well, if we quit there, we're going to miss over 20% of our STEMIs. What are the strategies we need to use? When you get the 12 lead, how often you get the 12 lead, where do you put the electrodes? So just the dynamic nature of STEMI, isolated posterior STEMI, and whatnot. Even when there is no elevation, going beyond that basic interpretation, again, it is simple. That will increase correct recognition of people who need to go to the cath lab by greater than 20%. Okay, now that we say correctly there's ST elevation, here's the real world issue. There are so many causes of ST elevation that numerically, statistically, when you find elevation correctly, it is more likely to be from a non-ischemic cause than it is to be from STEMI. So more than 50% of your cases that have elevation, that meet the STEMI criteria, that elevation is from a STEMI imposter. Bundle branch block, ventricular rhythm, whatever. There's over 20 of them.
Men hvis der er over 20 imposters, altså efterlignere, så bliver det tæt på umuligt for os ikke at drukne i alle de muligheder, der pludselig er.
Statistically, of those 20 some odd STEMI imposters, 5 of them are the chief suspects. They're the usual troublemakers. And if I have ST elevation and I can rule those 5 things out, the probability of that elevation being from STEMI goes way high. Left ventricular hypertrophy in a large left ventricle, bundle branch block, right or left, or even non-specific interventricular conduction delay, ventricular rhythms, paced or spontaneous, early repolarization, a normal variant that's common with young healthy males, and pericarditis. Depending upon your population demographics, various studies, those 5 things accounted for 84% of all the cases of non-infarct ST segment elevation.
Jeg har arbejdet med LP12 og LP15 i nærmest lige så mange år, som jeg kan huske. Men begge maskiner, altså det vi kalder DFI'en, ligesom alle andre DFI'er, har faktisk nogle egenskaber. Jeg har dog altid fået at vide, at jeg skal stole mere på min egen fortolkning af ekg'et end på maskinens. Hvad skal du ikke gøre som det første, når du får et nyt EKG i hånden printet fra DFI'en? Tryk på pause og tænk over det.
If I ask people to finish this sentence, everyone can do it. Here's the phrase. Treat the patient not, and everyone in unison says, the monitor. And I go, I cringe when I hear that because it's a false dichotomy. It's implying you're either going to treat the patient or you're going to treat the monitor, when in reality, it's both. You need certain information from the patient that the device cannot give you. But there's information on your 12 lead that you cannot get from examining the patient or listening to their story. So it's a both and. It's not an either or. Published studies, one of these studies that I'm referring to, where they had a false positive rate of 66% when you just use the device's statement to activate. There was over 40,000 pre-hospital 12 leads where they had a known outcome. And when you saw the STEMI message, 2 times out of 3, 66% deemed to be false positives.
Så det er både og. Også fordi din DFI, uanset hvilken DFI du har, rent faktisk har nogle spidskompetencer, som i sidste ende kan spare dig for en masse fortolkningsbøvl. Her taler Tim om LP15, den nok mest udbredte maskine i landet.
There are certain things that your algorithm can do quite well. Certain things it does extremely well that we're particularly interested in. And if I know my device does these certain things well, then I'm going to incorporate those aspects into my decision making. I'm going to view the device's statement as my second opinion. It's measurements, it's math, it's adjusting it for the patient's age and their sex. Devices are great at that.
Venstresides grenblok er en af de efterlignere, vi snakkede om før, og det kan du komme udenom ved at identificere Scarbossa-kriterierne. som er en konkordant ST-elevation på mere end 1 mm i afledninger med positiv QS-kompleks, og konkordante ST-depressioner på mere end 1 mm i V1-3 og udpræget store diskordante ST-elevationer, der er mere end 5 mm høje. Eller de modificerede Scarbossa-kriterier, hvor der skal være en udpræget, meget stor diskordant depression på en eller flere afledninger, der har en elevation på 1 mm eller mere, og som samlet udgør en forskel på 25% eller mere af den S-takt, der gik forud for den pågældende elevation. Fik du det? Jeg kan godt forstå, hvis ikke du gjorde, for det kan være svært at huske, og det er ret sjældent, at vi støder på en situation, hvor vi skal bruge Scarbossa-kriterierne.
For example, some devices have the Scarbossa criteria built in. So if your patient has a left bundle branch block, the Scarbossa criteria is how you would suspect a heart attack in the presence of a left bundle on the ECG. I could teach anybody the Scarbossa criteria. I could teach a 5-year-old the Scarbossa criteria. The question is, if you haven't used it in 9 months, and here you are at 2 o'clock in the morning looking at a left bundle branch block, are you going to remember it and apply it correctly? Well, if you know that your device has that built in, that's an important thing to know. So the two primary gauges, clinical presentation, ECG findings. But I think the sweet spot is to learn what your device does well and integrate those aspects. If you have a LifePak 15, you then have the Glasgow algorithm. And the Glasgow algorithm, whenever it encounters a left bundle, will apply the Scarbossa criteria. And if that left bundle branch block meets the Scarbossa criteria, it won't say Scarbossa, it'll simply say STEMI. Brugada. What I tell people is if you have a syncopal patient, near syncope, weakness, whatever, just do a 12 lead. And if it says Brugada, you got to take them to the hospital. But if your device says Brugada, it doesn't prove that they have Brugada syndrome, but they have Brugada pattern on the ECG. They need to be evaluated because those exact waveform changes may be gone by the time they get to the hospital. Those are the people that are subject to episodes of VTAC and VFib. It's great at checking for left ventricular hypertrophy. Every time you do a 12 lead, it's going to churn and burn. It's going to do the measurements, do the math, adjust for age, adjust for sex every time. And if you've got ST elevation and that device does not say meets voltage criteria for left ventricular hypertrophy, you can confidently scratch the number one STEMI imposter, boom, right off your list. Here's another one. It's going to measure the QRS duration reasonably well. If you look at the QRS and you think it's within normal limits in its width, and the device measures it at less than 0.12 seconds, functionally, you can get rid of bundle branch block and ventricular rhythm. So knowing what the device does well makes a difference. Last one, huge important feature, ST segment monitoring. It'll do a repeat ECG every 30 seconds. If it sees a change in one lead's J point of even 1 millimeter up or down that persists for 2.5 minutes, it'll automatically print out a new 12 lead for you. STEMIs are like geysers. They can have elevation 1 minute, gone the next, back again, gone. And if we think we can do a single 12 lead and catch as many STEMIs as we're going to catch, that's just crazy talk. If you have a LifePak, do your initial 12 lead as early as you can, leave all the cables attached. It'll, in the background, do those sample ECGs. And if it prints out an ECG that you didn't ask for, take a good look because at least one of those J points has changed.
Det sidste der var jeg personligt ikke klar over. Altså, at der er en så specifik grund til, at maskinen spytter et ekg ud, vi ikke har bedt om.
One really well-designed EMS study, urban and suburban, found that 15% of all STEMIs would be missed if you aren't doing either serial ECGs or ST segment monitoring.
Inden vi fortsætter, vil podcastens sponsor lige sige et par ord. IMS podcast er støttet af Falk Danmark. Fremtidens sundhed er vores fremtid. Så Falk tror på kompetenceudvikling og nye udfordringer. Det sikrer patienter, det sikrer gode kollegaer, og det sikrer god behandling. Pas på jer selv, og god vagt. For at koge det ned, er der 3 ting, du skal gøre for at komme godt på vej mod at identificere et STEMI på dit EKG.
I can think of 100 simple points.
Ja, men i virkeligheden er der 3 simple ting, du skal gøre.
Before the ECG is obtained, take a few seconds before you apply the electrodes to prep the skin. The number one issue producing artifact is the electrode-patient interface. It's the gel. The better that gel penetrates, the deeper that gel penetrates, the stronger the signal from the heart, the weaker the signal from the sources of artifact, the cleaner the ECG. Take an alcohol prep, quick scrub. Take a washcloth, take a gauze pad, follow that up with another quick scrub. You'll wipe off skin oils, you'll wipe up some dead cells. Now when you apply the electrode, not only will it stick better, you've already gotten rid of a lot of things that would hinder the gel's ability to penetrate. It is shocking to people the difference that skin prep can make. If you don't have a clear ECG as your starting point, it doesn't matter who you are, it's hard to interpret it. And we tend to sometimes give ourselves a pass. We go, oh, we're EMS, we're special, we're moving, we can't get a clear ECG.
Endnu en ting, jeg altid har fået at vide. Vi skal holde stille med ambulancen for at lave et godt EKG.
If you go to the stress lab, they have people running on treadmills, and they can get a clear ECG.
Så sæt elektroderne ordentligt på. Tør huden af, hvis der er uro på dit EKG, og brug et par sekunder på at klargøre til at optimere kontakten mellem elektrode og hud. For det andet.
Don't wait for something to jump off the page and demand your attention. I'm a paramedic, so I can say this without hopefully offending anybody. If we wait for something to jump off the page and demand our attention, on one hand, we're going to miss ST segment elevation when it's genuinely present. And on the other hand, we're going to make snap decisions and call things elevation when they're truly not. Quick examples. Let's say you have 1 millimeter's worth of J-point elevation, just a millimeter. And let's say that QRS amplitude is huge. Proportionately, that 1 millimeter of amplitude doesn't strike your eye because the amplitude of that QRS complex is huge. And you just go, yeah, that looks good. But if that exact same 1 millimeter of elevation is from a QRS of 3 millimeters in height, low amplitude, it's obvious. If you don't actually find the J point and you don't actually measure it, you can be deceived by common things. Next one that will deceive you is a notch in the QRS. Hint, notches do not mean bundle branch blocks necessarily, but we commonly encounter notches. Take a second to actually go lead by lead and actually find the J point and check to see if it's elevated.
Brug et par sekunder på at finde det J-punkt. Altså punktet på ekg'et, der markerer afslutningen af QRS-komplekset og starten på ST-segmentet. For det er på den måde, du sikkert kan gennemskue, om der er tale om elevationer eller depressioner. Brug det i din strukturerede tilgang til aflæsning af ekg'et, så du ikke begynder at se ting på papiret, der enten ikke er der, eller du bare brændende ønsker at se. Hvad er et non-STEMI? Tryk på pause og tænk over det eller google det. Et non-STEMI er en afart af akut koronarsyndrom, altså AKS, hvor der er en AKS-anamnese med brystsmerter, svimmelhed, koldsved osv., men hvor der ikke er ST-elevationer på ekg'et. Diagnosen stilles sammen med anamnesen på baggrund af forhøjet koronarmarkører, altså troponiner. Og sidst, men ikke mindst.
And then point number 3, think in terms of yes, no, maybe. If you have elevation, could be a STEMI. You want to drill down and rule out the imposters. If you don't have elevation, there's a whole slew of things that we want to think of to try to find that hidden STEMI. Serial ECGs, ST segment monitoring, that's part of it.
Den strukturerede gennemgang af ekg'et, hvor du fjerner så mange tvivlselementer som muligt og lander med en høj sandsynlighed for, at der er tale om en elevation, der hænger sammen med et STEMI. ekg'et sammen med de kliniske fund.
Get a clear ECG. Find the J point correctly so you can, yes, say there's elevation that meets the criteria, or no, that's not, and be correct. And then once you correctly determine whether or not there's elevation, then you remember, okay, now let's put this on the spectrum of possibilities. Yes, no, maybe.
Det bliver ikke simplere, tror jeg. Altså, også selvom det kræver træning at blive god til de kritiske aflæsninger af ekg'er. Der er kun én vej og ingen smutveje. Du skal læse så mange ekg'er som muligt.
if you've done it right once, you've done it right once. You've just got to get your reps in. There's just no shortcut. And that can be done through a variety of means, but you need to just practice the approach and get feedback on it. There's just no shortcut.
Tim har faktisk udviklet et helt nyt 4-timers online-kursus, som du kan deltage i. Det er faktisk så nyt, så det ikke er helt klar endnu. Så hvis du vil være ekspert i at genkende STEMI på 4 timer, så er du nødt til at melde dig til på Tims hjemmeside ecgsolutions.com, trykke på Contact og udfylde formularen. Så får du besked, når kurset er klar. Alle, der lytter til IMS podcast, vil få en rabatkode. Næste gang.
Jeg hedder Lasse Bensen. Jeg er læge og aktuelt så under hoveduddannelse til speciallæge i akutmedicin i Kolding. Så har jeg en baggrund som ambulanceassistent, hvor jeg er uddannet i Holbæk, blev færdig i omkring 2012. Man kan tænke, de fleste krampetilfælde, altså hvis vi snakker kramper, de varer mellem 90 og 120 sekunder. Ikke? Der er som sådan ikke behov for at behandle det, kan man sige. Men du ved ikke, hvor længe de varer. Og når folk ringer, så er de bange. Og så foregår der et eller andet, de ikke selv kan håndtere situationen. Så det ene ting, det er at håndtere selve patienten. Det andet, det er jo også de pårørende omkring dem. Når nogen ringer med nogen, der har et krampeanfald, så ved man ikke, hvor lang tid det kommer til at vare. Man ved heller ikke, om patienten vågner op igen efterfølgende, om de får flere krampetilfælde. Og det skal behandles, fordi hvis de ender ud i det, vi jo kender som status epilepticus, så står vi faktisk med en livsfarlig tilstand, som kan slå folk ihjel og ødelægge deres hjernekapacitet ret hurtigt.
Kramper. Vi har midlerne, vi har alle sammen set det, men jeg er også ret sikker på, at vi alle sammen har stået med et tilfælde, hvor vi egentlig ikke mener, der er tale om i citationstegn rigtige kramper, men hvor pårørende mener, der er tale om status epilepticus og grand mal, eller grand mal, eller grand mal, eller hvad det nu hedder. Altså det helt store, universelle krampeanfald. Omvendt har vi helt sikkert også alle sammen stået med tilfælde, hvor vi var i tvivl om det, vi havde set, rent faktisk var kramper. Det er næste gang i IMS podcast.
Jeg hedder Lasse Bensen, og jeg er akutmediciner i Kolding. IMS podcast er støttet af Falk Danmark. Tak til Tim Phalen for hans store bidrag til episoden og for hans viden og indsigt i emnet. Tak til alle dem, der har bidraget med gode idéer og kritisk input. Alle er velkomne til at komme med feedback og idéer, og alle, der gider skrive, vil få et svar. Gå ind på podcastens Facebook-side eller Instagram-profil og kommenter, eller på podcastens YouTube-kanal og skriv der. Det er der allerede mange, der har gjort, og det har ført til stærke bidrag og fedt indhold. Tusind tak. Det fedeste er og bliver, hvis jer, der lytter, selv er med til at bestemme indholdet af IMS podcast. Så mens du tænker over, hvad du gerne vil høre mere om, så klap din kollega på skulderen, fortæl hende eller ham, at hun gør et godt stykke arbejde, og frem for alt nyd din næste vagt.
Som en sidste lille kommentar til det her afsnit, så husk på, at hvad end der er blevet sagt, og uanset hvad der findes af studier og forskning, der understøtter det, der er blevet sagt, så skal I for jeres egen skyld holde jer til de instrukser og procedurer, der er gældende lokalt, der hvor I kører.